Well, good morning, everyone. It's a great pleasure and a great honour to be speaking to you, sharing with you my experiences over the years, and I hope to just reinforce the fact that Professor Shulsky remained young and active and dynamic, and my talk will exemplify that. So these are the individuals who have guided me, and they remain my key mentors, both in terms of my own development as well as international collaborations. And it's a great honour, actually, to pay homage to Dame Sheila Sherlock, Professor Roger Williams, both whom I work with very closely, and then late John Walsh. I hadn't worked with him closely, but he was pioneering into both diagnosis and treatment of Wilson's disease. And alive and kicking is certainly Professor Shulsky, and my latest mentor, Sir Alimuddin Zumla. So as you can see, these pioneers of Wilson's disease, they've really embodied and reinforced our understanding and the presentations of Wilson's disease, to the biology of Wilson's disease, then to the therapy and the cure. And as we now move into 2024 and beyond, we really ought to be thinking about how can we do some further good as a community, both in terms of global health inequalities in the area and the treatments and the advocacy, and building on what we're already doing some great work on. So this is the result of some of my collaborations, particularly with WDA over the years, and I'm really delighted that one of the places that I work at, the Royal Surrey and University of Surrey, that the WDA were instrumental in recognising some of the strengths that we have, particularly in terms of R&D, the clinical programme, and some of the advocacy programme from the UK. And you can see the R&D team with the ophthalmologist and with the neurologist. So it really is part of a multidisciplinary team that we really trying to strive for and really advocate for. So moving on, really the topic for this morning, what are the causes of Wilson's disease? Well, the ATP7B gene is central mutational genetic defect. The gene controls the protein involved in excreting excess copper from the body. And as you know, the mutations disrupt normal copper excretory mechanism and lead to slow and sometimes very rapid buildup of copper within specific organs, in particular the liver, brain, and eyes, and so forth. So this is the most important discovery in Wilson's disease, and three research workers, Bull et al., Tanzi, and Yagamuchi, in 1993 discovered the gene and published it in Nature Genetics. And thereafter, it's been well recognized and certainly reinforced that the condition can have a phenotype when you have genes that are homozygous or compound heterozygous mutations. And of course now, the area is so rapidly developing that there's now more than 600 mutations thus far. So what does the gene do? Well, the gene provides instructions for making a specific protein that transports copper from the liver to other parts of the body. And when this protein doesn't function, the protein builds up in the liver and brain, causing copper toxicity. And this is a key slide that Dr. Shulsky and I published in the Lancet. This is one of our first publications over the years as a labour of love in this area. And as you can see, we've identified and reinforced the key copper proteins which are involved in copper metabolism and cellular localization. As you can see from left to right, the uptake of copper usually occurs at the basolateral area of liver cells through a copper transporter protein called CTR1. Then there is a mechanism of which ATOX1 is a copper chaperone, which helps the transport of copper into the cellular space. So ATP7B really has two main functions. The first function is that the Golgi network activates ceruloplasmin, which is the transporter protein of copper, and then the cytoplasmic vesicles aid the sequestration of excess copper into vesicles. So as you can see here, So as you can see here, the key mechanism of copper excretion is in bile canalicus, and transported with copper, with ceruloplasmin rather, is into the circulatory system through the sinusoidal space. So these are the two mechanisms by which copper can escape. Moving on to the inheritance of Wilson's disease, which I know will be very dear to many people of the audience. The condition is inherited as an autosomal recessive condition, and those affected can have then pass on to 25% probability of their loved ones. In other words, unaffected son or daughter, and then the carrier status of 50% probability, and then the affected of 25%. Then, if you look at this slide here, which was given to me by late Mary Draper, bless her, from WDA, you can see. Sorry. Got very excited there. So you can see that if you are affected by Wilson's disease, then the chances of you passing on to your children will be that there is 100% carrier status onto your children. And then for your grandchildren, there will be 50% chance of them being Wilson's disease carriers. But the slide reinforces the fact that it's critical that if you are diagnosed with Wilson's, that your siblings get tested. It's really crucial because we are not doing enough testing on siblings. Then this is an important slide where recent data has shown that we can't simply just ignore because as you know, the gene is part of a homozygous or a heterozygous process. But if you only have one copy of the gene, then 1 or 2% of the population only carries one copy of the gene, right? But if you have one copy of the gene, you're unlikely to have the extreme copper disturbance that we normally expect in someone with Wilson's disease. But there is, of course, a decreased serum ceruloplasmin in 20% of people who have one copy of the gene. And recent data, particularly from the Aarhus group, the Danish group, suggests that there are some subtle copper disturbances, actually, particularly within the liver. And as you can see, there are some increased copper accumulation within the liver in the heterozygote state. But that said, one copy of the ATP mutation retained does give you slightly more copper than the controls, but it's not pathogenic. I repeat, not pathogenic, and it certainly doesn't require treatment, despite it being relatively common. And this is a very important slide because this slide shows what's happening at the liver level. And it's very important to understand that Wilson's disease doesn't occur in isolation. It can also occur in other liver diseases. So beware of someone who, certainly we found this in my own practice at King's, where we've had a number of patients who masqueraded as alcohol-related liver disease or NASH, when in fact we should have really looked hard, very hard in fact, and in fact a number of times we've not quite appreciated the presentation of Wilson's disease, and to really home in on that diagnosis, particularly when you've got decompensated liver disease, we've really confirmed the diagnosis of disease with the NASH, with the alcohol-related liver disease when histology has been done. As you can see from this slide, there are typical cells within what's called the portal inflammatory area, and then there's specific cells also called glycogenated nuclei, which increases the suspicion of Wilson's disease in some of those cases, along with a couple of other key features such as mammary bodies and hepatocyte ballooning. But the picture can mimic fatty liver. Then this slide just tells you that there are similarities between a rarer condition called Menkes disease, where this is a mutation of the ATP7A, which prevents the absorption of copper from the intestinal lumen, and it also prevents copper from reaching the systemic circulation. compared to Wilson's disease, which is a mutation of the ATP7B, and this is, as I've said, this is a problem of the excretion of copper from the liver. And then this slide is an overall summary of really what we're dealing with, the fact that this is, we're dealing with a multi-system disease, of which two main organs are predominantly involved, and they are the liver and the central nervous system, or the brain, and or the eye. And then following that, there are other potential secondary symptoms that can occur in patients with Wilson's disease, and there are, as you see, related to skin problems, bone problems, gynecological problems, and even blood problems with hemolytic anemia. This is a slide which tells you that be vigilant. This is a slide that tells you that if Wilson's disease can present at any age, and in fact, Dr. Shilsky and I described the first case of a brother and a sister, sibling, where the disease was diagnosed in the early 70s. So in other words, the first patient was a 72-year-old female who presented with neurological Wilson's and subsequent liver failure, and then the exact gene in her younger brother was associated with, not with the same presentation, but actually with minimal neurological presentation, but a high hepatic copper. So the slide tells you that there are variations in age and variations of presentation. So leading us to think that there may be an environmental or an extragenic factor which is driving the different presentations of Wilson's. So this slide may be relevant to some of you in that it really summarizes that, is the cause of Wilson's disease affected by ethnicity? And really to say that any race or ethnic group can be affected, but there are variations in the different ethnicities. And as you can see, there are variations across the world, ranging from China to Middle East, and even some parts of Africa, Northern Africa in particular. So there's really a lot more work to do, particularly in teasing out the correlation between phenotype and the genotype. And as you can see here, the exact mechanisms behind that still remains to be unraveled. This is a quick slide that just tells us, that reinforces the fact that there are still lots of work needs to be done, and particularly in a multidisciplinary and in a collaborative way. This is experience from King's that tells you that that there are specific loss of function variations that may lead to specific forms of worsening Wilson's. And the final two slides is really a lovely collaboration which I had with WDA in 2018, where I was supported by WDA to go out on the WOW Walk of Wilson's at the time, and we actually had a 4-day meeting with the Pakistani advocacy group, and we drove the agenda for awareness, understanding of the causes, diagnosis, team building, and really access to treatment and future registries. So that concludes my talk. As I said, this is a collaboration of a number of colleagues, local, regional, and international partners, which have helped in the fight against Wilson's disease. And thank you very much for supporting us, and thank you very much for inviting us. Thank you.